The medial wall of the orbit is nearly vertical and is formed principally by the orbital plate of ethmoid bone. You can see it in this picture. This is the orbital plate of the ethmoid bone. This paper-thin rectangular plate covers the middle and posterior ethmoidal L cells, providing a route by which infection can spread into the orbit. The ethmoid articulates with the medial edge of the orbital plate of the frontal bone at a suture that is interrupted by the anterior and posterior ethmoidal foramina. And there is a anterior ethmoidal foramina and posterior ethmoidal foramina, and this suture is the frontoethmoidal suture. Posteriorly, it articulates with the body of sphenoid, which forms the medial wall of the orbit to its apex. This is the body of sphenoid bone. The lacrimal bone lies anterior to the ethmoid. It contains fossa for the nasolacrimal sac that is limited in front by the anterior lacrimal crest on the frontal process of maxilla. This is the anterior lacrimal crest of frontal process of maxilla, and the behind by the posterior lacrimal crest of lacrimal bone. And this is the nasolacrimal sac. To the posterior lacrimal crest, the lacrimal part of the orbicularis oculi and lacrimal fascia are attached. The descending process of the lacrimal bone at the lower end of the posterior lacrimal crest contributes to the formation of the upper part of nasolacrimal canal. There may be a nasolacrimal canal which is completed by the maxilla. During development, the medial wall of the orbit doubles in length with disproportionate enlargement of its anterior half. Growth is rapid during the first 6 years of life and gradual between 7 years and adulthood. But the floor of the orbit or inferior wall. This is the anterior view of the orbit, and if you see the orbit from this side, you can see the orbit's floor like this figure. It is usually the triangular shape and it is similar to the roof but smaller than the roof. Like this way, the floor of the orbit are shaped as a triangular. The floor of orbit is mostly formed by the orbital plate of the maxilla, which articulate with the zygomatic bone anterolaterally, and the small triangular orbital process of the palatine bone posteromedially. In this figure, we can find the maxilla like this, and this is the zygomatic bone portion, and the small orbital process of palatine bones I colored as blue. The floor is thin and largely roofs the maxillary sinus. Below the floor, there will be a maxillary sinus. Not quite horizontal, it ascends a little laterally. To the lateral, the floor ascends the upper direction. Anteriorly, it curves into the lateral wall, and posteriorly, it is separated from the lateral wall by the inferior orbital fissure. This is the inferior orbital fissure, which separates the lateral wall. And this inferior orbital fissure connects the orbits posteriorly to the pterygopalatine fossa and more anteriorly in the intertemporal fossa. So it means that under this inferior orbital fissure, far from your side, there will be a palatine fossa, and in the anteriorly below this figure, infratemporal fossa. The medial lip is notched by the infraorbital groove. This is the infraorbital groove, and this is the infraorbital groove. The groove passes forward and sinks into the floor to become the infraorbital canal. It means that gradually, like this one, groove to canal, which opens on the face at the infraorbital foramen around here. I drew too far actually. The infraorbital groove, canal, and foramen contains the infraorbital nerve and vessels. While passing through the infraorbital canal, the infraorbital nerves gives out the important branch, anterior superior alveolar nerve. Proportionally, more pure orbital fractures involve the floor, particularly in the region of the infraorbital groove. The classic blowout fracture leaves the orbital rim intact and typically interrupts the soft tissue structures, leading to diplopia, impaired ocular motility, and enophthalmos. Infraorbital nerve involvement leads to ipsilateral sensory disturbance of the skin of the midface. Of the orbit is the lateral wall. The lateral wall of the orbit is formed by the orbital surface of the greater wing of sphenoid bone posteriorly. In this figure, this is the greater wing of the sphenoid bone, and the anteriorly the frontal process of the zygomatic bone. This is the frontal process of zygomatic bone. They meet at the sphenozygomatic suture here. The zygomatic surface contains the opening of minute canals for zygomaticofacial and zygomaticotemporal nerves. The zygomaticofacial nerves near the junction of the floor and lateral wall, probably around here, and the zygomaticotemporal nerve are located at a slightly higher level, sometimes near the sphenozygomatic suture. The names of these openings are zygomatico-orbital foramen, orbital foramen. The orbital tubercle, to which the lateral palpebral ligament and the check ligament of the lateral rectus muscle and the aponeurosis of levator palpebrae superioris are all attached, lies just inside the midpoint of the lateral orbital margin. Around here, there should be an orbital tubercle. It is a slight elevation. The lateral wall is the thickest wall of the orbit, especially posteriorly, where it separates the orbit from middle cranial fossa. Middle cranial fossas are around here, and the lateral wall is the thickest wall of the orbit. Anteriorly, the lateral wall separates the orbit and infratemporal fossa. The lateral wall and roof are continuous anteriorly, continuous around here, but are separated here by a superior orbital fissure. Superior orbital fissure lies between the greater wing and lesser wing of the sphenoid bone and communicates with the middle cranial fossa. The fissure tapers laterally. It means like this one, but widens at its medial end around here. Its long axis descending posteromedially. Where the fissure begins to widen, its inferolateral edge shows a projection, often a spine, for lateral attachment of the common tendinous ring. Another name of this common tendinous ring is the annulus of Zinn. Okay, let's look at the orbital fissures and foramina. There are 6 foramens or fissures in this area. I will write down the name of those structures. Number 1, optic canal. Here. And number 2, superior orbital fissure. Here. And number 3, inferior orbital fissure. And number 4, anterior ethmoidal foramen. Here. And number 5, posterior ethmoidal foramen. Here. And finally, number 6, zygomatico orbital foramen around here. Okay. The optic canal. The lateral wing of the sphenoid is connected to the body of the sphenoid by a thin flat anterior root and a thick triangular posterior root. The optic canal lies between these two roots and connects the orbit to the middle cranial fossa, transmitting the optic nerve and its meningeal sheaths and an ophthalmic artery. So, optic nerve and ophthalmic artery pass through the optic canal. The common tendinous ring, which gives origin to the 4 recti muscles, is attached to the bone near the superior, medial, and lower margin of the orbital openings of the canal. Around here. And the diameter of the cranial opening of the optic canal increases significantly during the fetal period and childhood into adulthood. Next, the superior orbital fissure. The superior orbital fissure is the gap between the greater and lesser wing of the sphenoid bone, bounded medially by the body of the sphenoid and closes at its anterior extremity by frontal bone. Here, it connects the cranial cavity with the orbit and transmits the very important structures, quite many. The oculomotor nerve, and trochlear nerve, and abducent nerve, and ophthalmic nerve. Some branches of ophthalmic nerve and ophthalmic vein. Next, the inferior orbital fissures. The inferior orbital fissures is bounded above by the greater wing of the sphenoid bone and below the maxilla and the orbital process of palatine bone, this and this, and laterally by zygomatic bone. The maxilla and sphenoid bone often meets at the anterior end of the fissure, excluding the zygomatic bone. And the inferior orbital fissures connects the orbit with the pterygopalatine and infratemporal fossae and transmits the infraorbital and zygomatic branches of maxillary nerve and accompanying vessels and orbital rami from the pterygopalatine ganglion and connection between the inferior ophthalmic vein and pterygoid venous plexus. Inferior ophthalmic vein. Next, ethmoidal foramina. there are two ethmoidal foramina. The anterior and posterior ethmoidal foramina usually lie in the frontal ethmoidal sutures. This is the frontal ethmoidal sutures, and there are two foraminals, anterior and posterior. The posterior foramina may be absent, and occasionally there is a middle ethmoidal foramen. The foramina open into canals that transmit their vessels and nerves, have the same name, anterior, ethmoidal, nerve, and vessels, and posterior, ethmoidal, nerve, and vessels pass through their respective foramen. The foramina open into canals that transmit their vessels and nerves into the ethmoidal sinuses, anterior cranial fossa, and orbital foramen. This foramen contains the zygomatic nerve into two facial foramen, the zygomatic foramen and zygomatic temporal foramen, and has the respective names of the nerve.